Greetings, everyone, and welcome to this webinar. My name is Emmanuel Fo, and I'm Technical Director with USAID's Medicines, Technologies, and Pharmaceutical Services Program. We welcome you to this webinar hosted by MTaPS, the Medicines, Technologies, and Pharmaceutical Services Program. MTaPS is a USAID program implemented by Management Sciences for Health, along with a consortium of partners. The MTaPS program aims to enable low and middle income countries to strengthen their pharmaceutical systems to ensure access to safe, effective medicines and supplies. So the program has been a 6-year program and working in several low middle income countries. And we have worked in about 24 countries counting from when the program started in 2018. So today we have this webinar on procurement. And as we know, procurement is often seen as the beginning of acquiring medical products for use in healthcare systems. And it's a very important, a key part of all what goes on within the health system, because without quality products, you will not be able to have good patient care, treatment, and patient outcomes. But then when procurement goes wrong, then it can mess up everything. So today we want to take some time to look at procurement, but focusing at subnational procurement. There is procurement happening at the central level, but there is also procurement at subnational level in many countries. And we want to look at that with a focus on maternal, newborn, and child health commodities because of the challenges that have been seen with these commodities and for these programs. So today we're going to start off with setting the stage. We're going to have Debbie Ambrosta set the stage about why it is important to pay attention to the procurement of maternal and newborn child health commodities. But just before we do that, just a quick run to the program that we have. We would like this program to be interactive, so we have set aside time for discussions, and we will invite you to put questions in the chat as we go along, and then during the discussion time, we will take those questions to provide additional information. So in addition to that, we will also want to hear from colleagues in Nepal about the situation of subnational procurement, after which we'll do a run of the global guidance that came from the work that MTaPS did in Nepal, providing some global guidance on procurement best practices. And then we will look at the Global Health Supply Chain Procurement Supply Management Manual for procurement and supply of MNCH commodities. This will be followed by a deeper dive to look at what Nepal is putting in place now regarding the guidance, and also look at some perspectives from Nairobi City County as another country experience. Then we will have time for the discussion. Like I said, we will discuss questions. Throughout the webinar, feel free to use the chat, to exchange ideas and ask questions. And if you have suggestions and experiences you would like to share, please feel free to put your contact details in the chat so that participants can follow up with you to continue this dialogue and discussion to see how we can contribute to improving subnational procurement. We plan to share the presentation, the recordings, and the chat transcripts after this event. So to set the stage, we'll be inviting Deborah Ambrosta. And who is Debbie? She is a Senior Maternal Health Advisor at USAID's Office of Global Health. She is a nurse with a master's in public health and a fellow of the American College of Nurse Midwives. She has over 30 years of experience in safe motherhood and reproductive health programs in over 25 countries. At USAID, She was a lead for USAID's work with the UN Commission on Life-Saving Commodities for Women and Children, and is currently a team member of the and technical advisor on the MCHN Commodities Supply Team. She's part of USAID's team that orients and oversees MTaPS MNCH portfolio. Debbie, please tell us why local procurement is important for MNCH commodities. Over to you, Debbie.
Sorry, I was on mute. So first of all, a good morning, good afternoon, and good evening to all, and welcome to this webinar. I want to start by thanking Jane and the MTaPS team for inviting me to open the webinar on local procurement. It's really an honor. And to thank Jane and her colleagues, Kate Kikulu and Maria Teixeira, for highlighting and working on issues related to MCHN in the world of commodities and supply chain. In 2021, 5 million children died before their 5th birthday. Nearly half of those deaths were newborns. And a maternal death occurred almost every 2 minutes in 2020, almost a third caused by postpartum hemorrhage. Most maternal and newborn deaths are preventable with timely and appropriate treatment from quality life-saving commodities such as oxytocin and misoprostol, which many of you know, postpartum hemorrhage, and amoxicillin, which treats sepsis for both children and newborns. MCHN products are typically procured by national procurement agencies with government funds. And this is compared to products for malaria, HIV, family planning, and TB that are predominantly supplied through donors. This means that governments, rather than donors, are responsible for ensuring availability, affordability, and quality of MNCH commodities. And quality has been something that has been a particular concern of mine for quite a while. Some countries have decentralized health commodity procurement to subnational entities, like a region, a province, a county, or a district, thereby shifting responsibility for product selection, affordability, and quality assurance to subnational teams, who often lack the resources and capacity to appropriately fulfill these responsibilities. This is the situation to some degree in most settings, and I saw personally when Nepal devolved their government and the municipalities were provided 30% of the budget. So the municipalities or the LLGs, which included procurement of most MCHN meds. MTaPS has done some great work in Nepal to work with the government to identify the problems and barriers related to this subnational procurement. And they've held meetings with all levels of government to facilitate work to mitigate these issues. You're going to hear a lot more, which is really important, and I look forward to it too, about it during this presentation. In other settings, even if procurement is done centrally, subnational entities can purchase medicines and supplies themselves to mitigate stockouts. And this is often from an unreliable government procurement and supply system. My first experience with issues related to subnational procurement was in Ghana. And it's, they're not speaking today, but they probably have a lot to say about this too, where the policies and pricing of the National Health Insurance Agency didn't always keep up with the market, which encouraged pharmacy reps to visit facilities and sell medicines directly to them more cheaply than the government could. And the pharmacy reps would even deliver the meds, and which wasn't happening for facilities. So it was a pretty good deal for them. So this problem hasn't been solved today, but Ghana is really trying to address and work on these issues. If subnational procurement is not conducted carefully, product quality, affordability, and ultimately availability may be compromised. Countries are trying to make progress on the SDGs and advance universal healthcare, which both rely on access to quality MNCH meds. Improving subnational procurement practices could be a valuable contribution to achieving these goals. Using its experience in a few countries, MTaPS has developed some procurement best practices for subnational entities and countries to consider. So in addition to Nepal, we're going to hear from Kenya today, which will also be great. These practices are not specific really to MNCH medicines, but applying them to subnational procurement for all essential medicines, including MNCH, will improve the quality of services provided to women and children and help reduce preventable maternal, newborn, and child deaths. And with that, I turn it back to Emmanuel, and I really look forward to hearing the rest of the webinar. Over to you.
Thank you very much, Debbie, for setting that context. And as we can see, it is very critical that procurement is done right for us to be able to contribute, to the health goals, especially around maternal, newborn, and child health. So right now, I'm going to invite Baburam Humagain. Baburam is professor at the Central Institute of Science and Technology College, Pokhara University, and is a freelance consultant in Kathmandu, Nepal. He formerly was principal technical advisor with USAID MTaPS program based in Nepal. And in that role, as one of his activities, he helped to conduct a mapping of local procurement practices in Nepal that he will be sharing with us right now. So over to you, Baburam, and thanks for joining.
Thank you. Namaste from Nepal. Good evening, good morning, and good afternoon. Thank you for the wonderful introduction, Emmanuel. Next slide, please. I'll be talking about the subnational procurement. The study conducted last year through MTaPS and with the help of our consultant here. So before I start my presentation, I'd like to talk about some background information about the health system organogram of Nepal. We have a Ministry of Health and Population at federal level, under which there are three important departments. The Department of Health Services is one of the important department and then the largest department to look at after the health services. The another department is the Department of Drug Administration, which looks after the drug regulatory affairs. And we have also another department that looks after the Ayurveda and alternative medicines. We have 7 provinces under the federal government, which are also regarded as the provincial government. And each province are having Ministry of Health or Ministry of Health and Population, under which there are Provincial Health Directorate, Provincial Health Logistic Management Centers. So this Provincial Health Logistic Management Center is basically responsible for the procurement of the medicines. And there is another level of government, that is local government. We have 753 municipalities and 77 districts and primary healthcare centers, health posts, urban health promotion centers, community health unit, and also EPI centers. So this structure was implemented after the federalization in Nepal, after the new constitution in 2015. The government of Nepal has given high priority for the MNCH services and are a part of basic health services delivered at all levels, from high to peripheral levels health facilities. And basically the MNCH products are procured subnationally, either from the municipalities or from the provincial level. Next slide, please. Next, yeah. So we had two purposes of this study. The first one is to assess the procurement practices at subnational level to assure the quality of MNCH medicines procured by the subnational entities. The second objective was to identify options for the government to develop strategies to improve the subnational government. These two were the basic objectives of our study. So regarding the method, it is a mapping. So we selected 4 provinces out of 7 provinces, and which included 17 districts out of 77 districts. And we also included management division under the Department of Health Services, 2 provincial ministries out of 7, 2 out of 3 provincial units of Department of Drug Administration, that is a regulatory authority. And we also included provincial health directorate. Out of 7, we included 4, and also 4 provincial logistic management centers were also included in the mapping. So under the municipal level, we included 4 out of 276 municipalities, 4 out of 11 metro or sub-metro cities, and 4 out of 460 rural municipalities, 3 health officers, and 4 out of over 6,000 health post or PSCC or hospitals. So basically the 3 provinces at the east part, and the Modest province and Gandaki province and the Kosi province and the Bagmati province, 4 provinces were included in the mapping study. Next slide, please. So how do finding compare to good government practices? We basically focused or based on the WHO model quality assurance system for procurement agencies that was developed in 2007, and also based on the pooled procurement of drugs in LMICS CGD 2019, and the guidebook for setting up an operating framework agreement to 2021. So under this, next slide, please. So what is regarded as good procurement practices? The core objective of good procurement practices are to provide value for money and to maximize the use of available resources. These are the 2 core objectives. And the characteristics of under this, the good procurement practices are, there are procedures, written procedures, formal written procedures in place, and there is explicit criteria for evaluating bids and awarding contracts to ensure quality, price, as well as availability. And process has integrity and generates fair and open competition. And lastly, there is transparent, impartial, and accountable processes. So under the good procurement practices, we have taken this as a baseline reference under which we were evaluating the outcomes. Next, please. So what we found, whether there are formal, written, and clear procedures and responsibilities, unfortunately, the local government, especially the municipalities, do not have standard operating procedures or guidelines on procurement specific to the medicines. There are some guidelines with regard to the procurement of machines or equipments, but the study did not find any standard operating procedure or guidelines on the procurement specific to medicines. Some local governments have developed procedures procedures for just developing the bid documents. None were designated to procure the pharmaceutical, because pharmaceutical is specific. The number of items are large, but the whole documents was found to be focused the equipment's procurement, but not specific to the medicine procurement. Next slide, please. So what we found on the transparency, they use electronic, the government procurement system. They use, but not the local government. Very few local government or local entities, they had electronic procurement system. The provincial level, they have started, they were following EGP, but not at the local level. And there was lack of human resources, and the capacity of the human resources, basically in the local level government, to use even this electronic procurement system. And no legal arrangement for regular monitoring of transparency by federal and provincial government. Actually, after federalization, the local government itself, they think they are all in all for every activities, and we didn't find any connection, any monitoring mechanism from the federal or the provincial government. And interestingly, there was no civil society role in monitoring the procurement, local procurement. And we also didn't find formal procurement related reporting from one level government to another. So there is no reporting, and there is lack of monitoring from the province or the federal level. And also we found that the audit reports are not published publicly. There are audit reports. The government attorney, they perform audit, but the audit report was not found transparent to the people. Next one, please. So this is another important finding with regards to the value for money. What we found, a large variation in the procurement prices. For example, oxytocin, the price variation was 9 to 43. So this is almost 5 times differences. Similarly, on misoprostol, we found even 10 times difference. Magnesium sulfate, about 4 times difference. So lower level generally paid substantially higher prices. And there is widespread use of direct procurement. Direct procurement means they can just, there is a limit, budget limit for direct procurement. It is up to 500,000, I guess. So this amount of procurement, they can 500 or 100,000. It is directly they can procure from, even from the retails. So basically the health post or lower level health facility, they found, the procuring magnesium sulfate or the oxytocin from the, pharmacies. So directly from the pharmacies, 10 ampoules or 100 ampoules or something like that. So next slide, please. Well, how the resource is used. We found that the budget generally do not cover the needs. This has created a question: is health a sufficiently high priority for the local government? This is the question. And there is duplication and poor coordination between the different government level. Multiple procurement units purchase the same medicines, with some medicines not procured at all. And this has led to waste of resources. If you see the right side of the slide, it explains about the medicine flow system of Nepal. The budget comes from donor or the government source that goes to the federal government, that to the provincial and the local government, the federal government, about 30% that goes to the local level. And the procurement, the procurement is done in the central level for especially the family planning, community vaccines and emergency drug. And centers, there are, program like TB, HIV, malaria. These program centers also procure medicines. And at the provincial level, the Provincial Health Logistic Management Center, basically responsible for procurement of essential medicine as buffer stock. And the health office district also have some, authority to procure medicines in emergency conditions. And basically the municipalities, the local level government, which is responsible for essential medicines and health facility also, they can procure some MNCH special medicines. So these all medicines are stored in the respective store, and the distribution goes through PHLMC. PHLMC is the Provincial Logistic Management Center to the district health office, and the district health office supplies to the municipal store. So municipal store supplies to the health facilities. So here, in the past years, what happened immediate after federalization, there was confusion in the procurement by different entities. So this finding, I think this has been little changed these years. Dr. G will be explaining about the changes in the duplication, but in previous years there was duplication, especially in the procurement by the province as well as by the municipalities. So some medicines even not procured by any entity, and some, there is duplication in the procurement, which has led to the overstock also. Next slide, please. So monitoring procurement and supplier performance, we didn't find established mechanism or system for LLG or provinces to report problems with supplier. There is hardly any practice. There is practice, if any item supplied by the central system and that fails to on analysis, the central government or the Department of Health Services circulates to the the provinces and the municipalities, especially the districts, but no established mechanism for LLG or provinces to report problems with the supplier. Hardly we could see any complaints. Procurement law allows for action to be taken against supplier for poor performance. Yes, in case of quality failure, some action might have taken, but we couldn't find any such the action taken. Neither the municipalities nor provinces were found to have taken action against supplier or poor performance. Next slide, please. So regarding the quality assurance, yes, some visual inspection upon received at local level. They perform visual inspection. They just verify the name of item, whether that item is exactly the same or not. But performing any quality assurance severely lacked technical human resource, especially the pharmacist, to evaluate the received items. Even the administrative human resource are involved. Little or no knowledge and quality evaluation, reviewing the documents. So that is why they just, they go through the name of item, and that is all. So while the procuring, they ask for the registration certificate, and some they ask for the whether the company is GMP, WHO GMP certified or not. That is all. So, but the document produced by the supplier, they are never verified with the regulatory authority whether they are the supplied, the submitted document is genuine or not. So health facilities require none of these when buying directly from the pharmacies, because they do not ask to just go through the name of the item. Next slide, please. I think this is the last slide. Regarding the pre-qualification of suppliers, the Procurement Act of Nepal allows pre-qualification. Unfortunately, it is not in practice in all levels. They did not know, even some entities, they do not know they could, and they lacked the administrative and professional capacity to conduct a pre-qualification exercise. Now, we have also suggested for the going through if they can pre-qualify the suppliers and the manufacturer, even the manufacturer, then there is a stage of control, quality assurance could be performed. So I think this is all from my side. Next slide. So now I would like to hand over to Jen Brick, Senior Principal Technical Advisor, MNCH, USAID MTaPS program. Over to you, Jen.
Okay, good. Thanks, Abraham. Before Jen speaks, I wanted to just say a little bit about my colleague. Jane Briggs is Senior Principal Technical Advisor with the Medicines, Technologies, and Pharmaceutical Services Program, MTaPS. I have worked with Jane for close to 2 decades now, and I just admire the passion and the personal interest she has in good maternal, newborn, child health programs. She does this work with a lot of passion and devotion. And she also leads the MTaPS work in the maternal, newborn, child health portfolio. And she led these studies, mobilizing and bringing together the needed resources to have what we are sharing today. So much thanks to you, Jane. She will be presenting the recommendations that led to the global guidance, doing so on behalf of another technical expert, our colleague Malcolm Clark, who could not join us today. So I invite you, Jane, to do the presentation. Over to you, Jane.
Thanks very much, Emmanuel, for that introduction. Alicia, if we could go to the next slide, please. So it was great to have the overview from Nepal to really highlight the problems that they found there with subnational procurement. I think Babaram nicely highlighted issues related to pricing and quality and duplication in procurement. And so as we were supporting Nepal to go through those findings and consider their next steps, we put a lot of thinking into generating country-specific recommendations. And this built on some previous work that we had done looking at subnational procurement in Nigeria, Tanzania, and Liberia, where we also saw similar challenges and similar solutions. And so after we saw that the recommendations were well received in the stakeholders workshop in Nepal, we packaged it into this generic guidance of best practices for subnational procurement of MNCH medicine. And as Debbie very clearly explained at the beginning of this event, it is particularly relevant. Subnational procurement is particularly relevant for MNCH medicines, as they're frequently procured at the subnational levels, and also that there are particular quality concerns for some of those medicines. So for example, oxytocin that needs to be stored in a cold chain throughout the supply chain to ensure effectiveness. It's not enough for it to be manufactured and stored at the wholesaler level in the cold chain, but then up country where it's being procured at the subnational level, it's no longer in the cold chain. So quality issues are key for some of these MNCH medicines. Although clearly this guidance is relevant for subnational procurement of any essential medicine. And just a reminder, when we say subnational procurement, we can mean provincials or district levels or even individual facilities procuring. And as Baburam alluded to in his presentation, often it's a mixture of all of that. Next slide, please. So just to go back to the core objectives of good procurement practices that Baburam alluded to in his presentation, these should be part of central as well as subnational procurement. And so our guidance document dwells on these a little bit that are kind of cross-cutting principles, if you like, to apply to subnational procurement. So first off, there's value for money and optimized use of resources that are available. And so central to this is determining the demand for products across as many facilities as possible and aggregating that at a higher level. And there is a study that found that aggregating demand and awarding contracts to larger suppliers could lead to savings as large as 50 to 75% compared to individual decentralized procurement. There needs to be transparent, impartial, accountable processes that are followed with integrity. So here we're talking obviously about fair and open competition, criteria by which to evaluate the bids and award contracts, and to provide quality assured products at a good price. Also, we want monitoring of local procurement to maintain that transparency. There also needs to be information that allows comparison of prices between facilities, among facilities, so that there's better negotiation with suppliers. And I think this is one of the points that Baburam mentioned from Nepal that they didn't see too much of, is that really, ideally, we'd want to have the engagement of civil society to oversee procurement and budgeting in a way that complements formal government oversight. The third point that he mentioned was that there should be the use of written procedures. This is stressed in our guidance as well, that there should be clear, documented, standardized procedures and guidelines for subnational procurement, which is particularly helpful for personnel who lack technical expertise. And it also gives a framework for conducting reviews. Next slide, please. The last principle is around systems supporting achievement of good procurement practice and assuring product quality. Good procurement practice is not carried out in isolation. It needs to be underpinned by systems. For example, you need systems to quantify the demand based on need, and these should be robust quantification with a standardized approach and the use of quality data at all levels. So this clearly highlights the need for strong information systems that are used, and that data is assessed and analyzed. Products that are procured subnationally should be based on the essential medicines list, which is often according to level, as well as obviously the standard treatment guidelines. We need a system to monitor and report on supplier performance, but also make sure that there are penalties for poor performance and that those penalties are enforced. And then lastly, as Debbie stressed so well in her introduction, we need to ensure the product quality. And so we need systems to assure that. Suppliers need to be pre-qualified. For example, we should only be procuring medicines that have a valid market authorization, for example. So there need to be systems underpinning this procurement that are assuring quality. The next slide. So in our guidance document, we suggest 3 different approaches to apply to subnational procurement to overcome the challenges that Baburam highlighted from Nepal, and we have seen in many, many other countries where subnational procurement is ongoing. So these approaches that can be considered are framework agreements, prime vendor programs, and lastly, e-procurement systems. Next slide. So firstly, looking at framework agreements, next slide. Framework agreements for frequently procured essential pharmaceuticals and supplies aggregate demand across multiple facilities, international or regional contracts, to leverage the buying power of larger volumes. Agreements are typically longer term, so the prices are fixed for up to 3 years, which is good for suppliers because it gives them security for better pricing and service. While contracting and price setting are done centrally, local purchasers make the buying decisions, drawing down on the framework agreement, and they continue to manage their budget. And so a framework agreement separates the supplier selection, contracting, price setting pieces from what is essentially the purchasing and budget management, in line with a decentralized system, and obviously facilitates transparent competition. In the next slide, we can see that there are many benefits to framework agreements. There's improved efficiency because it's a single procurement process rather than multiple procurements. There's enhanced visibility and competition. We know who's doing the fulfilling of the orders, at what price. Everything is more transparent. It's easier to assure product quality because we are fixing that the purchasing is being through suppliers with quality products. And there's better value for money through the economies of scale and ongoing competition. Next slide. Certainly, there are advantages, but there are also challenges in setting up framework agreements. And one major challenge that we'll talk to in a moment is that often public procurement legislation needs to allow the use of framework agreements. Framework agreements can reduce competition if there's no way to actually allow new suppliers to come in. So you have to make sure that there is possibility for new suppliers to enter that framework agreement. Otherwise, the system itself can become resistant to change and even vulnerable to collusion and corruption. There's a nice example in Liberia where some framework agreements were set up initially for 3 counties to allow those counties to top up supplies from private wholesalers where there were gaps in the supply by the central medical store. And there are numerous other examples as well. Next slide, let's take a look at the other approach that we're suggesting, which is a prime vendor arrangement. The prime vendor agreement is where there is a government contract between private sector wholesalers and distributors to supply medicines and medical supplies for public health facilities. So it's essentially a one-stop shop, and it can either be to supplement a traditional government supply system through central medical stores, and so alleviate stockouts, or it could be the primary supplier through prices that are agreed through a central contract. A nice example of prime vendor is in Tanzania, where there's a public-private partnership called Jazia, where health facilities procure priority quality assured medicines directly from a prime vendor through contracts that are negotiated regionally. And that complements the regular government supply from the central level. So in the next slide, we can see that the success of a prime vendor program depends on it stocking the medicines we need, meeting the demands of subnational procurers, but also on receiving timely payments from the government. If those payments are delayed, the prime vendor will stop supplying, and then facilities will revert to purchasing outside the system with all of the challenges that we've heard earlier. In the next slide, let me move on to the next approach. Next slide. E-procurement provides subnational governments with easy access to centrally negotiated contracts and prices, as well as facilitates transparency and standardization. We can see on the next slide the benefits of e-procurement, which include cost savings, adherence to procedures and legal requirements, better coordination and visibility into individual buyers' behavior and across the system as a whole, accountability, responsiveness. E-procurement systems also increase efficiency, not least because they eliminate the need for moving large amounts of paper between different levels of government, with it all being electronic. And also the fact that it's transparent appeals to suppliers of a different level, higher level suppliers, which improves service and product quality. But it's important to look at the challenges of e-procurement. It is a large, complex undertaking, and it's a comprehensive change in the way of doing procurement. It's not just an IT program. It requires significant budget and political support, but that often comes as a result of pressure for greater government transparency and efficiency. And so by establishing e-procurement, a government's role changes from managing the day-to-day procurement operations such as orders and invoices and tracking deliveries and so on, to overseeing the use of procurement contracts. And it facilitates monitoring and responding to contractual expectations. So this was a very brief overview so that we can move on to look at some of the country case studies where they're looking at some of these approaches that we've mentioned in this resource document. We hope that some of these principles and approaches resonate with you where you're already looking at subnational procurement in your countries and that you're already implementing them. So we will look in a moment at 2 country case studies. But before moving to those case studies, I wanted to share another important resource for those that are engaged in procuring MNCH commodities, which was published by the Global Health Supply Chain Procurement Supply Management Project. So the Manual for Procurement and Supply of Quality Assured MNCH Commodities. It's a really key resource on procurement. And so through collaboration between the 2 projects, we've included a summary of our guidance on best practices for subnational procurement as an annex to this document. And there's a link to our guidance in there. So let me hand over to my colleague, Siobhan. Siobhan Perkins is the Maternal and Child Health Deputy Director at the Global Health Supply Chain Procurement Supply Management Project. And she's going to provide a very brief overview of this extremely useful resource before we go into looking at the country case studies. So over to you, Siobhan. Thank you.
Thank you, Jane. And thank you all for allowing us to share this resource, one that we find extremely useful.
The Lord shall save us and the Lord help us.
As Jane mentioned, this manual that we developed in collaboration with USAID and partners was developed for procurement agencies and procurement specialists in procuring quality MNCH products. It contains general quality guidelines, guidance for procurement, such as WHO's Model Quality Assurance System, and information to support pragmatic approaches to ensuring the quality of products that have already been discussed this morning. But so specifically, I want to highlight just very briefly what we think is most useful is that it has specific quality requirements on a subset of priority MNCH products identified by the UN Commission on Life-Saving Commodities for Women and Children. Since that time, we've added additional products, including antihypertensives. So it includes PPH medicines, some antibiotics, TXA, and other products. So for those products, we have useful technical information that procurement agencies can use to establish specifications for the products to ensure their quality throughout the supply chain up to the point of use. So these technical information, I won't go through it all, but it includes key quality considerations, packaging and labeling, storage, stability, and degradation. We also have clinical particulars. And then finally, we provide a full list of up-to-date SRA and WHO PQ approved suppliers per product. So you can visit this QR code. You're able to download the full manual itself or portions of the manual or by product as interested. So thank you, Jane, for sharing this opportunity. Over to you.
Very good. Thank you so much, Simone, for being available to share this important resource and the emphasis on quality assurance system. Thank you, Jane. Thank you, Barbara. As we continue the story, as you can see, a lot of information. We invite you to pose any questions in the chat. we're going to have time to look at them. I also noticed that my colleague Andualem has been answering some of the questions. So please post questions in the chat and we will take time to answer them. And if you also would like to put a voice to it, that also is welcome during discussion. You can say or post your questions. We'll now move on to look at the country case studies and experiences. We want to make sure that this is well aligned with the realities of the countries that we are working in and trying to support. So we'll start by looking at what Nepal has done since these recommendations came out, the study and the recommendation. So I'll be inviting Mr. Bogendra Dotel, who is a public health expert and has worked within the Ministry of Social Development and Health and Population for many years. He was formerly Director of Management Division, Department of Health Services in Nepal, and is currently a consultant in procurement and supply management. Mr. Dugendra will provide an update on what is currently happening with subnational procurement in Nepal, the changes that have occurred since the mapping was carried out. So over to you, Mr. Abogendra.
Thank you, Emmanuel. Thank you for allowing me to share Nepal's effort to address the issues of subnational procurement. Next slide. Yes. Nepal, it had already been almost 2 years that Nepal mapping was taken, and I am going to present how much issues have been addressed and in the process of addressing the issues. If you look, I want to discuss some backgrounds as already been discussed by Baburam. Recently, Nepal has entered in the federal structure, and there are 3 levels of government. It's a federal level, provincial level, and the local level. All the 3 levels are procuring medicines. Since basic health service is free in Nepal, and also it is fundamental rights of the citizen, government has given high priority to improving the subnational procurement. Similarly, it is also realized by the policy makers that availability of medicines are the concerns of the citizens, and there is the importance of improving subnational procurement. Yes, maximum use of the resources and value for money can be achieved through a national policy guidelines. And thinking on this line, Nepal has recently published one public procurement strategic framework, which is called PPSF. It has been developed, and in the process of developing national procurement and supply chain management strategy with a costed implementation plan. And 2 provinces, it's a Lumini and Madhya province, have already been developed this procurement improvement plan based on this PPSF. Next, please. Yeah, I would like to give some highlights of PPSF for medicines and medical commodities, which is developed for a period of 2023 to 2027. Yeah, implementation of EGP. It's a National Electronic Procurement System of Nepal. It is mentioned that in our PPSF that by the end of 2023, 20% of all procurement will be through EGP, and similarly by the 2027, all the procurements will be taken through the EGP. And recently, I know that 2 provinces, shows that their use of EGP is above 90%. It shows that there is a good progress in the use of EGP. And most of the local levels are also using EGP, which is monitored by the Public Procurement Monitoring Office, Auditors General Office, and the Ministry of Health and Population. It's regarding the framework agreement. In each and every procurement related meetings, a need of framework agreement is discussed, and this issue is internalized at high level, but also need some legal and background work, and hence, you know, it's a it is in the PPSF, it is planned to pilot in 2025. Regarding the publicize the contract management to enhance the transparency and accountability, this practice has been started at Department of Health Services and other hospitals, big hospitals here at the federal level, and it is planned to cover in all procurement entities by the year 2027. Next slide, please. Yeah, information needed in procurement and supply chain mostly come from the ELMIS, that is Electronic Logistic Management Systems, and this ELMIS is rapidly expanding with the support of development partners. It has been in the system, health system, since last few years, and there is a plan to strengthen use of ELMIS and scale up in all health facilities. The capacity building is one of the important area, and that is taking place through PPMO. It's a Public Procurement Monitoring Office, and available of trained human resources is increased in health procurements. And Ministry of Health also plan to develop and updates the training manuals, and it is by the 2024 there will be a manual, and to address these issues of quality control medicines, guideline will be developed in 2024. So there is in PPSF there is a timeline, and the activities is listed. So currently there is only one pharmaceutical lab in the country at the federal level, in the capital city Kathmandu. So MOSP has in PPSF it is addressed that the need of provincial pharmaceutical lab is needed to improve the quality, and an organizational and management survey is planned for 2025. This organizational and management survey is prerequisite to establish any government institutions. Next slide, please. Formation next slide. Yeah, forecasting and pipeline monitoring of essential medicines and vaccines has been practiced since long time in Nepal, but it was only in the federal level. Recently, it has been initiated in districts as well as in the provincial level, where the need of the local levels, especially the municipalities, has been addressed, and it will definitely help to identify the total needs of medicines and the budget needed in planning, resulting is better use of the available resources. And regarding the list of medicines, Department of Health Services has separated the list of essential medicines to be procured by 3 different levels of government, and it will aiming that it will help to avoid the duplications, and also ensure the each and every items would have been procured. And effort has been made, especially in the increased effort to supply chain management through applying reverse logistics to avoid the wastage and greater oversight by the district team of supply chain activities. Next, please. Thank you very much. This is from the Nepal's effort.
Thank you so much for sharing this update. Very interesting to see the efforts being made, to improve on subnational procurement based on the findings and what we consider good procurement practice. So that's great. So thanks so much for sharing that with us, Dutel. We'll have another country experience. So I will be inviting Dr. Irene Mukoki to describe the situation of subnational procurement in Kenya, in counties, and also reflect on the recommendations that we have in this guidance document. So Dr. Irene Mukoki is County Chief Officer of Medical Services, Nutrition, Wellness, and School Feeding Program in the Nairobi City County in Kenya. She has been in this position for 1 year, and prior to that, she was the county pharmacist of the same county. Dr. Mukoki will describe the situation of subnational procurement in Kenya, speaking from her perspective at the county level. So over to you, Dr. Mukoki. Thanks for joining us.
Thank you, Emmanuel, and good morning, good afternoon, good evening, team. Yes, this is Dr. Irene, just like we have been told and like Emmanuel has said, and I'm happy to be here just to share our experience when it comes to procurement of health products and technologies, especially at what you're calling subnational level, which for us we call them at county level. And in terms of, just like to give a background, when it comes to procurement of commodities, mostly for Kenya, because health is a devolved function. And most of the aspects of health were devolved to the counties. Therefore, that includes even the procurement of all the health products and technologies, including all the MNCH commodities. So as such, national government under the Ministry of Health, mostly policy developers, and the policies are now cascaded to the county level. However, when it comes to procurement, we're still guided a lot, even in terms of legislation by the Public Procurement and Asset Disposal Act and regulations. So, which guide in all matters of procurement. That is something that has not even been custom made for any county. We use it, and we've adapted. All counties in the country have adapted this act and regulation just the way they come from the National Treasury. Procurement in Kenya, it happens at different levels, and that is at national level, at county level, and under the health function, even at facility level, especially what we call our higher level facilities, which offer specialized services. We have 6 tiers of health, 6 tiers of health services, which start from level 1 all the way to level 6. And just to clarify that, at level 1, we have what we call the community health package. Level 2 and 3, they offer what we call primary health services. And then level 4 to 6, we have what we call specialized services. Again, at overall, we have the Kenya Medical Supplies Authority as the national procuring entity for our health products and technologies in the public sector. And this is legislated. It's provided for in what we call the Cancer Act of 2013. Though there are some amendments due to public outcry and after experiences at the county level for the law to allow procurement of health commodities from other vendors apart from KEMSA. But overall, KEMSA still remains the vendor of choice for public health facility procurement. Next slide. When it comes to the procurement practices in Kenya, we have different methods of procurement, and we'll see that even in the next slide. And the methods of procurement, yes, thank you for that. We have, they are laid in the law, in the PPADA, and we have the open tender method, which is the most preferred, and it's because of transparency. And again, we have the restricted tendering, the direct procurement, request for quotation, and that one has a threshold. Anything below 3 million Kenya shillings can actually be procured under quotation. Then you have the low value procurement, competitive negotiations, framework agreements, and request for proposals. Those are some of the methods that are prescribed for public procurement in our country and even in our counties, which we follow in our counties. Next slide. You can see, because like I said, the open tender process is the most preferred method for procurement, and it's quite a complex cycle, just like it's laid out there. And I won't go into the nitty-gritties, but at least the slides will be shared. But that is what happens in the open tender process in even in Nairobi County. Next slide. As far as the local procurement in Kenya are concerned, in terms of successes, they are standardized, SOP, the standard operating procedures and guidelines on procurement. And actually, these are laid out in the acts, the Procurement Act and regulations. Again, we have centralized procurement, and this happens at national level. Still, the national level will do centralized procurement. Even at the county level, we do what we call county government level, we'll do centralized procurement. Again, we have decentralized procurement. And this is, like we said, under the facilities, the health facilities, the public health facilities themselves. This facilitates, faster decision-making, shorter turnaround times, and also at decentralized level, they're able to even procure that which may be outside what is given as a guideline. They're not really restricted by the guideline for what to procure in terms of health products and technologies. Again, also we have mixed procurements. There are those things you'll find, or those HPTs that you'll find will procure at the central level, and again, those that will be procured at the facility level. Again, we do the tendering process ensures transparency and accountability for the public funds, and of course, the prudent use of our public funds. And we have diversified financing models. We've been having the National Health Insurance Fund, but now it's been split into 3 funds. And we have what's called the Social Health Insurance Fund, and then we have the Universal Health Coverage Fund, and the Chronic Illnesses Fund as well. So the NHIF has now morphed into 3 funds so that it can actually facilitate different levels of health needs in the country. And we are going ahead now to adapt that even as counties in Kenya. Next slide. Again, we use the Integrated Finance Management Information System, the IFMIS system, which has both the finance modules and electronic procurement modules. So we've actually gone into the e-procurement fully this financial year. And our financial year starts from 1st of July up to 30th of June of the following year, of the following calendar year. So that is our financial year. So we've just moved into e-procurement fully this financial year. We are yet to appraise that. Again, at the county level, what happens with our finances? We collect monies and from our facilities when we offer the services, especially the upper level facilities, that is level 4, 5, and 6 tiers. So these monies are, they normally, what has been prescribed is that the funds first go into a central revenue account and then they are repatriated back into the facilities. So the Facility Improvement Fund is bill is supposed to allow the facilities, especially the facilities that have been collecting monies, to allow them to be able to appropriate funds at source, that is at the facility, without necessarily going through this red tape of going back to what you call the county revenue fund, the CRF account. So that will actually help us, especially when it comes to financing of health products and technologies, which is quite an issue with us. Again, we have availability of quantified and forecasted needs, HPT needs. HPT is here, it health projects and technologies countrywide. And this is done right across board in all the counties. Again, we're looking at leveraging on local manufacturing so that we're able to bring down the cost of HPTs. I was looking at the prime vendor program, and manufacturers are good. They can be classified to be prime vendors, although we have other prime vendors like in the private sector. And we have one called MEDS, and they work exactly just like the KEMSA that we've mentioned, but at the private level. Again, we have the public-private partnership model, especially for medical equipment. The MES is the medical equipment scheme, and this is a placement model. When you look at the PPP model, what happens is we have this partnership where a vendor will come and place the equipment in our facilities, and then there's an agreed way of operations, and it's guided. It's also guided by the law, and so that we're able to just ensure that we have quality services. So that is what we call MES, the medical equipment scheme. It was actually started at the national level and cascaded to all the counties. And the first round under MES of equipment we had mainly were on radiology equipment and a lot of lab equipment. And it's good, it's still ongoing, and contracts are drawn. The contract is from national level, although now it's been cascaded to the county level so that it's adapted at the county level. Again, another success is in stakeholder and collaboration engagements. And like we said, we've just moved fully into e-procurement system. Next slide. Of course, we experienced challenges, and you can see the listing there of inadequate budgetary allocation, and especially now post-COVID, the economy has really been affected. It's not doing so well. So budgetary allocation from the exchequer, from the national government, is it's been affected profoundly. So, but normally there's a percentage of what the exchequer gives the counties, and also counties from their own revenue sources, they're able to raise so that they meet all the needs, the budgetary needs for the counties. Again, low commodity availability. There's been a vicious cycle when we don't have enough budget, so we're not able to pay the vendors, and then it becomes a vicious cycle, especially for KEMSA, the Kenya Medical Supplies Authority, who are the main suppliers, and even other suppliers. So they're not able, the purchasing power is reduced because of not being able to pay on time, and also dwindling resources. Then conflict of interests is there, although there's a provision in the law to work on managing that. If there's conflict of interest, it must be declared at the time of procurement. Again, prolonged lead times. This is another issue. Sometimes you're not able to, you find the lead times. This is the time between the ordering, the time between when commodities are ordered and the time that they're delivered. Ideally should be around 14 days. Sometimes it takes quite a long time, because sometimes you find the commodities are not even available in the market. Some are imported, so you find they take time to get to the vendor and then to the facilities. and also erratic resupply of commodities. This has been an issue. It's one of our, it's quite an issue with us. However, we are working round to see how to ensure that the resupply is not erratic. Again, lack of skills and inadequate capacity to handle procurement at the lower levels. Now, the primary healthcare, at the primary healthcare level, level 2 and 3 tiers, because they just offer just the primary healthcare services, they are not empowered to do what, to go through the full procurement cycle. So, but currently what we're doing is we are mapping the level 2 and 3 tier facilities to the larger facilities. And through that, they can be empowered to do procurement using the upper level facilities, that is level 4 and 5. So again, for them, most of the time, because of lack of that capacity to do procurement at their level, most of the procurement is done centrally at the county level. And then we have the issue of uncoordinated stakeholder engagements, and this is another issue. This is another challenge, especially when it comes to stakeholders. Stakeholders will also provide HPTs to our facilities. So some of the solutions that we proposed are advocacy of adequate allocation of budgets. This one we keep pitching. Like now we're already into the budget cycle of the next financial year. Again, leveraging on innovative and alternative financing models, that is under public-private partnerships, private insurance, and we also have a community insurance model. So as a way of mitigating the stockouts in our facilities, so communities have come together, and what they do, they use our facilities as a conduit to be able to access health products and technologies, and even at a cheaper cost than what they would do if they were on their own. So we have several of our facilities where the communities have come together to form community-based organizations, and they are attached to a facility. And through the facility, they're able to procure medicines, at a cheaper cost, and they are able to access them at a cheaper cost, just because they're able to get together and leverage on that. And then, of course, capacity building and mentorship on the procurement processes, and this is ongoing. Next slide. Reflecting on the guidance document from MTaPS, it describes the pros and cons, of course, of decentralized procurement, and it has proposals on approaches to guarantee product quality and affordability, and a transparent, fair process. So generally, when it comes to framework agreements in Kenya, we've been using them, especially after devolution, and they're initiated through an open tender system, with specifications from the procuring entity. So when the open tender system, when the tendering is happening, for us to do the framework agreements, it must be declared. The procuring entity, we declare that we have the intention of going into framework agreements after the tendering, when we go into the tendering system. And most of them do not exceed a period of 3 years. That is already in the regulations of 2020. And just like Jane had highlighted, it's a preferred method, especially for HPTs, because it's less tedious, and again, it's very efficient, and we don't have to keep going back to the whole tendering process, which is quite complex, just like you saw in the previous slides. And also, we zero in on vendors who are able to provide good quality products. Of course, time management is one of the benefits as well. And yeah, again, maybe a profound disadvantage is that it might actually reduce the competitiveness, because if the vendors are given a time period of 3 years to operate, so you find now some people may feel locked out, but nevertheless, it's a welcome method of procurement, which is already ongoing. And as far as e-procurement in Kenya is concerned, and especially in Nairobi County, this is the time we are actually fully engaged in e-procurement. And actually, we started e-procurement in the financial year 2015, 2016, no, 2016, 2017, sorry. But then, because of lack of goodwill from the leadership at higher echelons, it didn't take off. So we were still, we still continued with the manual procurement. And yes, Jane, most of the counties are in using framework agreements, to answer your question, just because I've seen it. But I think we'll answer the questions as we go on. I'm sure we'll have time for plenary. In terms of e-procurement, one of the advantages is the giving visibility of the procurement process, and of course, tracking for the suppliers. They're very happy with it because of the transparency and accountability, and also being able to track the procurement processes. So just like I said, we started this financial year at the time that this government has now allowed and actually pushed all county governments to ensure that we're doing e-procurement. Kenya generally is, decision-making in Kenya generally is very political. So, and that resonates also with resource allocation. So currently, the current government, national government, they have actually pushed to ensure that e-procurement is the way that we're going to do our procurement. So we are yet to appraise. So perhaps if you have this meeting again after a year, I should be able to give you an appraisal of how the e-procurement is doing. But really, it's generated a lot of happiness to very many suppliers, our suppliers. And I think that is just about the end of my presentation. Thank you very much. Over to you, Emmanuel.
Yeah, thanks so much, Dr. Irene. I'm always fascinated at what goes on in Kenya. You know, it's one of those countries where people make effort to walk to talk. And you have really introduced a lot of, you know, key elements that are necessary for successful procurement. And we see some similarities with Nepal in the challenges and also the efforts being made to implement the measures that are being recommended. So this is very helpful information. Now I have a challenge with time. We're supposed to end in about 4 minutes. I would have loved to have a discussion. I know we've had an exchange in the chat. I don't know if there are still some questions in there that have not been answered. I know that I was trying to follow it too, but I don't think I've followed very well. Jane or Lauren or Alicia, is there any question that you think we should highlight in the next few minutes? There was one I saw from Dave about the medical equipment scheme, whether or not the provider, the vendor would supply and maintain the equipment. Would you like to speak to that, Dr. Irene? I know we're running out of time.
Sure, sure, Emmanuel, I can speak to that. Yeah, I saw the question. It's like a rental, yes, but the mess, yes, the suppliers, actually the supplier, we had a big vendor out of experience. It was one vendor and he supplied the equipment, and yes, the management of the equipment is on them. So they will commission, they will service, and under a contract agreement, the payments are actually negotiated between the government and the vendor, and the vendor who was offering the medical equipment. So you talked about rent. I don't want to call it rent. It was a contract, and it's still on. Now what has happened is the contract has been cascaded to all the counties, so that now the counties are the ones which are handling the MES scheme, the medical equipment scheme. And this is a good thing because the liability lies with the vendor. It's not with the government. So for us, we just pay for the service that the equipment helps us to, offer. So yes, that's it. Over to you, Emmanuel.
Yes, thank you so much. And I saw another question around the e-procurement, whether the suppliers are integrated in the system. Could you quickly, 1 or 2 sentences?
The suppliers sure, Emmanuel. The suppliers are registered under the IFMIS. All their businesses must be registered under the Integrated Financial Management Information System. So they have to be registered under IFMIS. They have an IFMIS number. So yeah, I don't know whether I've answered it correctly.
No,
I don't know whether I've spoken to that.
And thank you so much. Sorry that we seem to be rushing. Jane, did you want to put word to what the question around health products and technologies?
Yeah, I know that we're running out of time, but I think that Jane Wangi, if you're on the call, I know that you had a particular question on pre-qualification and how that's reflected for different categories of health products. I'm not sure whether you want to add some voice to your question. Maybe Jane's dropped off, but I think, you know, there are specifications around pre-qualification for specific MNCH medicines. Those product specifications are included in the PSM document on procurement of quality assured medicines. So for particular products, do take a look at that. But I think obviously that pre-qualification does have to be, you know, follow clear criteria, and those criteria are clearly dependent on the type of product. I think we're probably at time, Emmanuel. Thank you.
We're at time, and want to thank everyone for joining us. Please, we can all agree that procurement is key. Subnational procurement is challenged by capacity issues that limit the ability to comply with the best practices. And so additional investment, both in terms of HR, financing, and system are needed for us to be able to provide quality assured medicines for essential programs, as all of it. But we're talking here about maternal newborn child health because they also are products that have also suffered a lot from this. So please, let's take the message out. If we are policymakers, you are practitioners, let's continue to make sure that we can serve mothers, children, and populations that need help. So thank you once more. And at this point, we will stop. And please, let's continue with the contacts that have been exchanged. We'll be sharing the presentation and the recordings. Thanks, everyone, and goodbye.
Thank you. Goodbye. Namaste.